All right, thanks for attending CS 2-3 Psychosocial Considerations. As a reminder, please use the chat to add comments and the Q&A to actually ask questions to presenters. And it would be helpful if you could include which presenter your question is directed to. That's helpful for us when we review at the end. At the end of the session, we will try to address all your questions. And once a question has been submitted, you'll be able to upvote the question so moderators can identify important topics that we will designate during the Q&A. And with that, I think we'll get started with Dr. Cejas.
Thank you all for attending this session at our CI 2021 meeting. I'm Ivette Cejas, and I will be presenting on the impact and exposure of COVID-19 in parents of children with hearing loss, the relationship with mental health and PTSD. These are my disclosures, as well as my co-presenters, Dr. Sanchez and Dr. Cotto. So what do we know to date regarding mental health and hearing loss? In the literature, we've seen that children with hearing loss exhibit more behavioral or attentional difficulties compared to hearing children. In a recent publication that I published in Otology and Neurotology, we also found that there's a higher rate of depression and anxiety symptoms in adolescents with hearing loss. So specifically, we found that it's about 20% of our adolescents with hearing loss are experiencing elevated symptoms of depression and anxiety. Our studies have also shown that parents are reporting higher levels of stress related to parenting a child with hearing loss or with cochlear implants. And then when they interact with their children, they're also engaging in less sensitive parenting practices when compared to parents of children with normal hearing. With the COVID-19 pandemic, we're really seeing a heightened levels of stress regarding our nation. And in fact, over 50% of adults in the US are reporting elevated concerns regarding their mental health. A recent study also found that 18% of COVID-19 patients have developed a mental health issue within 3 months of a diagnosis when compared to those who have not had COVID-19. So this is nearly double the risk factor if you compare it to someone who has not had COVID. When we're talking about a negative impact of COVID, what are we talking about? So we're talking about increased feelings of fear, anger, sadness, worry, frustration. We're also talking about changes in appetite or sleeping patterns or things that you're interested in, difficulties with concentration or making decisions, or an increase in any physical reactions or headaches or somatic symptoms, as well as worsening of your chronic health symptoms or mental health conditions. So what about our deaf and hard of hearing population? What about the families that we are serving in our clinic? What do we know about how COVID-19 has impacted them? The reality is that it wasn't any data regarding what we should be doing to help our families that are walking into our otology and audiology practices. So at the University of Miami, we engaged our families who are enrolled in our children's hearing program in a web-based survey using Qualtrics. And we gave them several different measures, including a generalized anxiety disorder measure to assess for anxiety. We gave them a patient health questionnaire, which assesses depressive symptoms, impacts of events scale, which is assesses post-traumatic stress disorder and or related symptoms, a COVID-19 exposure and family impact survey, as well as some parenting surveys, the Alabama parenting questionnaire, as well as the parenting stress questionnaire. Those in bold are the ones that I will be focusing on during this presentation, but I also encourage you to look at our poster, which will highlight any relationships that we also found related to COVID-19 and the impact it had on parenting behaviors and parenting stress. So I wanted to spend a little bit more time just highlighting what exactly the impact of event scale is assessing. And so those questions in blue are looking at any type of avoidance behaviors. And those questions that are highlighted in green are looking at hyperarousal. And these are two main areas that we look at when we're trying to assess for post-traumatic stress disorder symptoms. The other important measure is the impact or the COVID-19 exposure and family impact survey. And this asks questions related to, were you in a stay-at-home order? Were your child's school closed? Anything that was disrupted in terms of your child's education? And then it also asks other questions that are rated on a Likert scale. What's important to see here is how do we define impact versus exposure? So impact, according to this survey, was defined as things related to parenting, ability to care for your child with hearing loss, physical well-being, mental or emotional well-being, eating, things along those lines. And exposure was more related to getting food, a change in your income, health insurance status, closure of schools, or whether or not you had been exposed to someone with COVID. So who participated in the survey? We had about 103 families complete this survey. Majority were mothers, and the majority also completed it in English, but we did also offer the survey in Spanish. 52% of the children were wearing a cochlear implant, and about 38% had a hearing aid. Parents, the majority were working on site or working from home or a combination, but we did have some that were furloughed, laid off in this sample. So what did we found? Overall, we're really seeing that there's heightened levels of stress, parenting or parent well-being. 34% were reporting that caring for their child with hearing loss had gotten worse or a lot worse. Parenting in general was more difficult. And surprisingly, over 50%, 50 to 60% were reporting changes or difficulties in eating, sleeping, and mood. When we looked at these, the anxiety and depression in more detail, we're seeing that about 53% of our parents of children with hearing loss are above the clinical cutoff in terms of anxiety, and about 16% are above the clinical cutoff on depression. This was really important in that we found that this was also related to PTSD symptoms. And so 20% were reporting heightened levels of post-traumatic stress disorder symptoms. But more interestingly, we also found that what was impacting PTSD was more of not your exposure to COVID, but more of the impact of COVID. So whether or not it was affecting your ability to care for your child or your ability to provide for your child, not necessarily whether you were around somebody or exposed to COVID. So what can we do about this? We're really seeing heightened levels of depression and anxiety, but only 7% were receiving services for mental health. So we really need to come together as a group. We need to be providing multidisciplinary care that includes mental health specialists, such as psychologists and social workers. And right now we're all a lot more familiar with telehealth, so we can use that as an advantage to connect with these families to make sure that it's not affecting our child's outcomes. Thank you so much for your time, and please feel free to email me if you have any questions about the study.
Hello, I'm Dr. Harper Wilson at the University of Kentucky, and I'm a preliminary general surgery intern, excited to speak to you about the impacts of the COVID-19 pandemic on communication and healthcare access for adults with hearing loss. This is a published manuscript with Otology Neurotology. The authors are listed. Matthew Bush is the head author on this project. This is my slide with disclosures. Some of our work was supported by the National Institute of Deafness and Other Communication Disorders. And Dr. Matthew Bush is a consultant for Mediel and Stryker. None of this is related to our current research. So there are a number of different proven social, economic, and health effects of COVID-19. Unfortunately, there are very disproportionate effects upon vulnerable populations. And some of these populations include the rural, or patients that are deaf or hard of hearing, among plenty of other populations. I'd like to focus on those specifically today, specifically the changes that affect the deaf and hard of hearing with respect to means of communication, business practices, and even public health recommendations that have already been proven. So let's take that a step further. Learning objectives for today are to discuss the impact of the COVID-19 pandemic on patient-reported communication challenges, different types of healthcare access, and mental and emotional health. And we'd like to compare these differences in adults with hearing loss, specifically comparing people who use hearing aids alone versus people who use cochlear implants with or without hearing aids, in addition to comparing urban and rural residents of Kentucky. Our methods involved a prospective cross-sectional questionnaire that was sent out via email and in paper from a tertiary referral center. And our inclusion criteria were adults with documented hearing loss, using either hearing aids or cochlear implants, one or two-sided with or without hearing aids. We also collected some socio-demographic data as well. Our questionnaire consisted of 5 categories of 48 total items. And the main categories broken down were communication challenges during the pandemic, pandemic preparedness and information gathering, and access to healthcare and access to hearing healthcare, as well as mental and emotional health. And as mentioned before, our comparisons were comparing hearing aid patients versus cochlear implant patients, and also comparing urban and rural patients. Overall, we had 614 responses for a response rate of 27.8%. Our demographics are listed here. Our genders were similar, but as you can imagine, given that we're at the University of Kentucky, the majority of our patients were predominantly white, predominantly hearing aid users, and a majority were urban. With respect to communication challenges, I think it's common sense to think that having a mask on is going to make it more difficult to communicate, but this acutely affects patients with hearing loss through the attenuation of sound and speech intelligibility, in addition to an inability to lip read. This also actually affects the deaf and hard of hearing when it comes to phone calls and video conferences, because the audio that they receive is not the same as an in-person communication. There are altered frequencies, problems with amplification. And again, if the video conference doesn't have a very clear view of someone's mouth and not synced well, it makes it more difficult to lip read. Here's our data with respect to communication challenges. If you look all the way down our hearing aid and cochlear implant column there, just off from the center, you can see that across the board, patients with cochlear implants experienced more difficulty with communication during the pandemic than patients with hearing aids. And this is most striking in terms of communicating with friends and family, in addition to using the phone or video conferencing. With respect to urban versus rural, there was also a significant difference in communication with family and friends, with more difficulty expressed by a rural population. Furthermore, difficulty communicating with people who are wearing masks was also sometimes more difficult in a rural population. With respect to preparedness in the pandemic, there are 2 aspects that we focused on: your primary sources and difficulty obtaining information. To our surprise, in this study, we found that among all 4 different groups of patients, each one of these groups prioritized obtaining their information about the pandemic from live broadcasts. And unfortunately, some of these people in these broadcasts, these reporters, were actually wearing masks. And if you look through our data here, there's a significant difference in terms of more difficulty with our cochlear implant versus hearing aid group, in addition to our urban and rural group. Access to healthcare is also another thing we wanted to address in terms of inconvenience and financial concerns that are already barriers to healthcare and healthcare needs. This is a more busy and involved figure, but what I'd like to point out from this figure is that people with hearing aids actually sought out healthcare more often than people with cochlear implants. But a significant difference here is that it was much more difficult for people in rural situations to reach healthcare during the pandemic. And again, knowing that inconvenience and financial barriers are also a proven problem in terms of accessing healthcare, this makes sense in this context. We also went over mental and emotional health, given that there's a heightened risk of depression amongst people with hearing loss, and there are also a number of significant social and emotional effects of COVID-19. Our data was significant for some figures here as well, and I'll give you a moment to look through this. There were also some pretext responses I thought were very interesting about patients staying home because they were embarrassed about not being able to hear, learning that they were more dependent upon lip reading than they anticipated before, and problems wearing hearing aids and masks simultaneously because of how it loops over the ear. Overall, our research highlights the communication challenges faced by patients with cochlear implants more so than hearing aids, and in rural more so than urban populations. And we hope that this shines light on this population of more vulnerable adults in a way that could potentially facilitate the use of clear masks in surgical and in healthcare environments that enable more communication and ways to improve internet access and video chatting and phone capability for patients with hearing loss. Thank you for your time.
All right. So I would like to present to you some initial findings about older adults with hearing loss and their self-reports of social isolation and how that relates to self-efficacy, and what we might be able to do with this information. So just a brief overview of kind of what we do at Ohio State and what, where this research is coming from and what's motivating it. We're really trying to optimize the outcomes for adults with CIs, and we hear that a lot. We're going to optimize outcomes, but we want to take a broad view and even look deeper into defining those outcomes and how we define success. So we have what's called a comprehensive CI clinic, where we have a speech pathologist, audiologists, surgeons, all working together with adults who have cochlear implants from their candidacy through post-op and beyond. And we know that cochlear implants improve hearing. We know it improves speech recognition outcomes. We know that it improves quality of life and social outcomes as well to a certain degree, but that's not really been the focus, especially clinically. So the questions, we ask ourselves, are patient-reported outcomes directly targeted in routine clinical care? And can we target them? Can we treat them intentionally and directly if we aren't measuring them or we don't really understand what those are? And so we had a luncheon for Dr. Moberly's lab participants, maybe 2 years ago, going on 2 years ago now. But we had a poll where they could text in their answers, and we asked, how do you define success with your CI? We wanted to know how patients define success. We're defining success clinically, traditionally with speech recognition measures. And this is what they said, and you can see that it goes beyond speech recognition. So that was good validation and motivation to kind of move forward with what we were doing with our clinic. And, potentially all these things could be outcomes that we're measuring and treatment targets in one way or another. We just have to figure out, what those treatment targets might be, how they affect the outcomes, how we're going to best measure them. So we're working on all of that. But we know social isolation, especially for older adults, can be a detrimental consequence of both aging and hearing loss. We don't routinely measure it. We don't explicitly target it in hearing healthcare. But this study used a group of older normal hearing adults and compared them to experienced CI users who had very good speech recognition scores. And we really wanted to see, does a CI, for someone who has experience at least a year and a half with their cochlear implant, and they have good outcomes, how they traditionally be defined, are they performing on par? Are they reporting social participation or social isolation on par with their older normal hearing peers? So yeah, we had 18 experienced CI users in this study, 15 controls. The ECIs all scored above 70% on a word recognition test. And then we gave them questionnaires from the Promise Bank of social self-efficacy and social isolation. We put those into a regression, and we found that the hearing status of group membership accounted for 21.2% of the variance that we saw in those social isolation scores, and about 15% of the variance in social self-efficacy. And so in general, the cochlear implant patients were scoring more poorly than the normal hearing adults on both of those measures. In addition, social self-efficacy partially mediated this relationship between hearing status and social isolation. And I think that that's important because it's potentially something we can treat. We can work through our counseling and rehabilitation on patients' confidence in social situations. We can give them tools, strategies, we can give them structured practice. We can really target their individual needs so that they are feeling more confident, and potentially, if it is mediating that relationship, it could improve what we're seeing here, that even though they have good outcomes, how we would traditionally define them in their speech recognition scores, they're not on par with their peers who don't have hearing loss. They're more socially isolated. So I think that this is exciting. And I hope that we can study this further with more subjects, with better analyses, and in a more sophisticated way, and eventually look at some potential ways we can treat it and study that as well. So with that, thank you so much for listening, and my contact information is there. That is our team. We might be missing a couple people, it might be out of date slightly, but that's our team in the clinic. We have clinicians, researchers. It's really a great comprehensive place to work and do new things.
Hello, I'm Elaine Smolen, and I'm here with my colleague Elizabeth Rosenzweig. Along with Maria Hartman, we are excited to share with you our study, Adoption of Children with Hearing Loss, Parents' Perspectives. So we were interested in learning specifically about the experiences of parents who have adopted children with hearing loss because there is no literature out there that we could find that looks specifically about deaf or hard of hearing children and their experiences being adopted. But we also knew that there's a huge need for this type of research. We all had worked professionally with parents who have adopted children with hearing loss. And we also knew that there are really vibrant online communities, both on social media and otherwise, that were supporting parents and supporting parent-to-parent connections of people who have adopted children with hearing loss. We also had a personal interest in this topic, and we were really specifically wondering what motivations, experiences, challenges, and strengths were identified or experienced or described by parents who have adopted children with hearing loss, either internationally or domestically. So this is where we came from with our study. We first wanted to gather just some quantitative data because there was nothing really out there describing the types of parents, the types of families who have adopted children with hearing loss. So we put out a call online for people to participate in our online survey. We got 49 participants who contributed quantitative data, and then 22 of those participants contributed qualitative data. So 11 of them participated in video interviews, and then 11 of them participated in written interviews. All the participants were female and all identified as mothers. They ranged in age from 25 to over 60. 2 of them had adopted over 1 child with hearing loss, so more than 1 child with hearing loss. 3 of those parents were deaf or hard of hearing themselves, and all the rest had typical hearing. And we had a really diverse range of professions, from stay-at-home parents to business analysts to nurses and professors. Interestingly, several of the parents worked in the field of hearing loss as interpreters or audiologists or teachers of the deaf. We had a diverse range of ages at which children were adopted. Many of them were adopted over age 6, which was interesting. Most children had sensory neural hearing loss, and most children had profound hearing loss, although there was a mix. So we got that quantitative data, which just gave us a snapshot of the families who are out there who have adopted children, but we wanted to look more deeply at parents' perspectives. So we took the 11 video interviews that we'd done via video conference, and we used a technique called thematic analysis to look at these semi-structured interviews. We professionally transcribed the interviews, then we did repeated active reading by everyone on our research team to really kind of code what parents had said and try to define and name the themes in their experiences, which Elizabeth will talk to you about now.
So when we looked at these common themes, one that we wanted to explore was what motivated these parents to adopt children with hearing loss. We found that some reported religious motivation, some adopted because they were unable to have biological children, some parents adopted for humanitarian reasons. They saw a need of children living in institutional care, and many of the people, when speaking specifically about why they chose to adopt a child with hearing loss, cited some kind of prior experience. They had a sibling with hearing loss, they worked in the field, they had been drawn to learn sign language, something like that in their past. We wanted to look at what these families had experienced with the identification and diagnosis of their children's hearing loss. And one thing that really complicated their clinical course was receiving unclear information about the etiology of their child's hearing loss or their specific diagnosis pre-adoption. Many of the medical records that families received, either if the child was coming from the domestic child welfare system in the United States, the child may have had multiple placements and no real continuity of care. Adoption records from other countries may have been translated, and translations are not always accurate. We also found that many parents, when they began the adoption process, really differentiated between hard of hearing and deaf. And if they did not have prior experience with hearing loss, felt that hard of hearing was more manageable, which in some ways tracks with what we experience clinically, but in other ways doesn't speak to the fact that any degree of hearing loss is going to have a significant effect on this child's communication development, and this child will need special services. Many of these children did not receive any kind of audiological services or rehabilitative services in their home country, and that parents making connections with other parents and professionals was really key in how they experienced this diagnosis. They experienced shock and grief, just as we see sometimes in biological parents when the child is identified through newborn hearing screening, but the grief was less about the child's hearing loss, which the parents often knew about beforehand, and more about missed opportunities. When parents have to make these technology and communication decisions, just as for all parents, it's often not just what you know, but who you know. And many of these children missed the window for age-dependent services like early intervention, and may not have had access to that parent coaching if the child is identified when they're already in the school system. Many of the parents who had prior experience with hearing loss also kind of challenged their fundamental assumptions. One quote from a participant was, "It's one thing to work with the deaf, it's a whole other thing for that to be your child." And so some people who felt very strongly about American Sign Language professionally chose differently for their children because they wanted them to have access. Parents reported difficulty. This was harder than they thought. Other people were insensitive. There was a lot of polarization in the field. But regardless of philosophical orientation, we found the parents to be purposeful, determined, and very unwavering in addressing their children's needs. So what are our implications for practice? We really need to make a hearing screen and speech language screen routine for all children who are adopted. And we need to really consider that all communication is essentially about relationships, and that attachment and language are inextricably bound. And the more that we as professionals can understand about parents' experiences and children's experiences to provide trauma-informed care, the better our outcomes will be. Thank you so much for your time.
Hi, my name is Kathryn Wiseman, and I'm going to share my research on the experience of siblings of children with cochlear implants. So when we work with children who use cochlear implants, most of our focus is on the children themselves. But these children grow and develop not in isolation, but within a family system. As they develop, they interact with and react to their caregivers, parents, grandparents, and siblings. So to understand a child, it can be helpful to consider their family system as a whole. So one important part of the family system is the sibling. So today I'm going to talk about siblings and their relation to children with cochlear implants. So why are siblings important? Sibling relationships can be an important aspect of a child's development. Siblings can provide emotional support and advice. They can model things like navigating social interactions with peers, good communication with parents, and provide a good practice in terms of conflict resolution. However, in a dyad where one sibling has typical hearing and the other a cochlear implant, a child's hearing loss may affect the dynamics of this relationship. So this work examines school age and adolescent children, including typical hearing siblings whose brother or sister use a cochlear implant. So this study aimed to understand the siblings' perspective of this cochlear implant user and the impact of hearing loss on the sibling. We also wanted to see how these experiences and feelings related to characteristics of the children. So things, for example, like birth order or child age. So this study included 36 children with typical hearing between the age of 8 and 17, whose brother or sister had at least one cochlear implant. Ages of siblings and the CI users were similar, with equally reported gender distribution and fairly balanced birth order. This study took both a quantitative and qualitative approach to answering these research questions. So for the quantitative approach, we used two sets of questions. One asked questions about the sibling's perspective of the CI user, and the second asked questions about the effect of the child's hearing loss on the sibling. So scores of these surveys were on a 5-point scale. So in the case of the sibling perspective questions, a higher score meant that the sibling had a more positive perception of their brother or sister. And for the effective hearing loss questions, a higher score meant that the sibling felt more affected or impacted by their brother or sister's hearing loss. For the qualitative portion of this study, we asked open-ended questions that allowed the siblings to express their experiences being a brother or sister to a CI user. Looking at the quantitative results, we found that siblings generally had a positive perception of the CI user. They highly rated items relating to the CI user's esteem, enjoyment of school, self-worth, and knowledge of the CI and of the hearing loss. Overall, the siblings see the CI users as unique individuals who are thriving. The siblings didn't indicate feeling strongly impacted by their brother or sister's hearing loss, and generally gave low ratings to feelings of resentment towards the CI user and towards their parents. Of the factors that we investigated, communication ability was the only one that related to a sibling state. So specifically, siblings that had a more positive perception or perspective of their CI user rated the siblings' communication as better. And siblings who felt less impacted also rated their siblings' communication as better. Looking now at the qualitative data, those data both supported and differed from the quantitative data. So most siblings commented on this, most of the comments about the CI user were positive. So for instance, one sibling wrote, "Instead of feeling farther apart from my brother, I feel closer to him." Comments about the impact of the hearing loss on the sibling were more negative than the quantitative data had originally suggested, particularly in relations to unequal attention from the parents. So the majority of the negative comments that were directed towards the parents rather than the cochlear implant users themselves. So for instance, one child wrote, "Sometimes I want to hang out with my parents, but if something happens to my brother's cochlear implants, they might not have time to spend with me." And finally, when siblings commented on the CI user's communication or social skills, it was mostly negative. So for instance, one child said, "It makes me upset when she is not acting normal with her friends and others that she meets. And sometimes it's hard for me to realize how much hearing loss really affects her." So here, this qualitative data allowed siblings to expand and share examples that we may not have tapped into with just the quantitative data. So to sum all of this up, these findings suggest that while many siblings of children with cochlear implants have positive relationships, some may still struggle with particular aspects of having a child with hearing loss in their family, particularly when the child has poor communication skills. So if siblings are feeling impacted by their brother or sister's hearing loss, there are a few recommendations that hearing health professionals can make to parents. One of the major themes that emerged from this study were that negative feelings related to differential parental attention. So parents can combat this by setting aside dedicated time to spend with the sibling to make them feel seen and feel valued within the family. Research of families of children who are deaf or hard of hearing supports the benefits of sibling support groups and camps that include siblings in order to allow sharing common feelings and needs. And finally, siblings might benefit from learning more about their brother or sister's deafness and their cochlear implant though the level of information needs to align with the sibling's desired level of knowledge. So thank you very much for listening to my talk. Thanks to the Cochlear Kids Camp who facilitated this data collection, to the families who participated, and to our funding sources and collaborators.
Good afternoon. My name is Grace Johnson, and I am a third-year medical student at the University of Central Florida College of Medicine. I would like to acknowledge my colleagues and mentors in this project, specifically Dr. Pritchett. I would like to thank the American Cochlear Implant Alliance for this opportunity to present our work. We have no conflicts of interest to disclose. Nemours healthcare system has been an ambulatory care practice present in Central Florida for nearly 2 decades. However, in 2012, NCH opened its doors as a freestanding tertiary care pediatric hospital. By the end of our study period, our team had grown from the original core audiologist, 1 surgeon, and clinical nurse to include 2 audiologists, 2 speech and auditory verbal therapists, 2 surgeons, including a pediatric otolaryngologist and neurotologist, nurse practitioner, clinical nurse, social worker, and dedicated team coordinator. 1 of our audiologists and 1 of our speech therapists are bilingual in Spanish. This afternoon, I will describe patient characteristics and the early outcomes in our program's first 5 years of existence. We retrospectively reviewed the EMR from 5 years of information for all cochlear implant recipients at our institution. We collected demographic information, including their race and ethnicity, gender, age at presentation and implantation, insurance type, and primary parental spoken language. We also collected time intervals for diagnosis to initial and secondary implantation and duration of time post-implantation to successful identification of all 6 ling sounds. All continuous variables were compared using non-parametric testing, including the Mann-Whitney U or Kuhs-Wallace. Categorical variables were compared using the Fisher exact test. Time-based analysis were performed using the Kaplan-Meier with a Mansell-Cox pairwise comparisons. The demographics of this population study include a total of 59 primary implanted patients and 25 secondary implants. Ethnicity includes 29 Hispanic and 27 non-Hispanic, and the primary spoken languages are English at 70% and English at 25%. Approximately 80% of the patients had Medicaid insurance. Between the years of 2015 and 2020, there was a decrease in the average age of the implanted patient from 8 years old to 6 years old. The length of time from diagnosis to primary implantation was roughly 2 years and roughly 3 years for secondary implantation. While subtle clinical differences may be present, there was no statistically significant difference in time to surgery based on race and ethnicity, insurance status, and primary parental spoken language. Mastery of the Ling 6 sounds is a fundamental building block on the journey to spoken language development. These 6 sounds are ah, e, u, sh, s, and indicate a child's ability to detect all aspects of speech, as these 6 sounds encompass the frequency range of all phonemes. In our program, 73% of the cochlear implant patients achieved Ling sound mastery during the study when followed up to 59 months post-implantation or to their final therapy appointment. 64% of the patients achieved mastery by 6 months. Once again, there was no statistically significant difference in the final percentage of children who achieved Ling 6 sound mastery based on language, race and ethnicity, or insurance status. On average, it took 3.5 months to achieve mastery of Ling sounds in the first implanted. The median time was 2 months. This time did not vary in a statistically significant manner, but the results were certainly more intriguing than in previously reported analysis. We definitely entertained the idea that clinical differences were present in the 2.9 months for children of English-speaking parents to achieve mastery versus the 5 months for children whose parents are primarily Spanish-speaking. Likewise, the 1.5 months to mastery in children with commercial insurance compared to the over 4 months for those with Medicaid. Interestingly, when controlling for insurance type, those with commercial insurance are statistically more likely to achieve mastery in a 4-month period than those with Medicaid insurance. Despite only being 22% of the sample, those with commercial insurance were 32% of the children achieving mastery and only 8.7% of those not achieving mastery in the 4 months after activation. Though intriguing, our study has limitations. Although our program continues to grow, the sample size is small. Therefore, it may be difficult to find significant relationships from the data. We continue to grow our program and add new cohorts to the research database. In addition, it is possible in our cohort that distance from the hospital is more impactful on the variables we have selected to study than the covariance we have present. The data is not presently available for presentation. In the future, we desire to explore and to investigate. In conclusion, despite being a new program, we find several valuable lessons and overall believe we are demonstrating desirable results. Cochlear implant teams should expect and be prepared for patients and families of diverse backgrounds to seek their services. Preventing patient socio-demographics from impacting time to care or early clinical outcomes requires intentionality and resources. And finally, a multidisciplinary approach is essential for comprehensive cochlear implant care. Surgical timeliness is only part of the story. Thank you.
Focusing on outcomes we haven't seen a lot of in the past, dealing with parents' impact, the impact of COVID on what we're trying to do with these children. And it's very, very interesting result. Unfortunately, I am unable to see your questions because of a technical difficulty. So Kara is going, I have questions of my own, but Kara's going to go through the questions you have submitted. Kara?
Yeah, sure. I'm very happy to do that. Technology is, challenging in these virtual programs, that's for sure. So the first question, and I think it is, I'm so sorry, the person didn't direct their question. I think it was for the second talk. No, I think it was for Dr. Ray. If that's incorrect, then we'll find the right person. For the relation among outcome measures, social isolation and self-efficacy, I was wondering whether listening effort is investigated as one of the outcome measures, because although patients might be able to sustain daily communication, maybe they're experiencing high effort, hence low efficacy and intentional isolation.
Yeah, I think you're right that the listening effort is a big issue for a lot of these adults with hearing loss. We have the measures that we have on listening effort come from the CIQOL, the CIQOL 35, which is the big quality of life patient-reported outcome measure from Ted McCracken and colleagues. And there's a listening effort domain or subdomain within that. And we do have measures on that. Interestingly, it doesn't seem to correlate with social self-efficacy or social isolation. It does seem to be, I could say clinically, what we see, although we haven't analyzed it, is that is the measure that is going to remain lower pre to post. So we see improvements on all of the subdomains, kind of except for that listening effort domain. So I think that is an issue, but it doesn't seem to correlate exactly with these patient-reported measures that we took for the study.
Thank you. We have another question with regards to Well, there's a question here. Sorry, I'm trying to go through them. So for Grace Johnson, would you please review the slide related to commercial and Medicaid and attaining the Ling sound check mastery?
Hi, this is Grace. Thank you for the question. Exactly what slide was it?
It was a slide related to commercial and Medicaid insurance and attaining Ling sound check mastery.
Okay. So when we originally did the study, we were looking at the results for commercial versus Medicaid, and there might be a little bit confusion between the clinical significant difference as well as the statistical difference. So when we were looking at insurance status, we were looking at the commercial versus the Medicaid and how fast they were able to achieve the Ling sound mastery. So for commercial, it took about 1.5 months to achieve the Ling sound mastery. However, in the Medicaid insurance, it was 4.4 months. So there was a significant clinical difference between the commercial versus the Medicaid and how quickly they were able to attain the Ling sound mastery. However, there was not a statistical difference between the two, but that could be due to the fact that we do have a smaller N value. So we don't have that many children in our study, but as we progress and we add data to our database, we might be able to find the statistical difference.
Thank you. So we have one for Dr. Smolen, and that is in regards, there's actually a couple on here. We'll give you the first one. In regards to adoption of children with hearing loss, were there specifically any audiologists adopted children with hearing loss? And if so, did they feel that negatively or positively impacted?
Yeah, that's a great question. In our sample that we just presented, we did not have any audiologists who participated in our one-on-one video conference interviews. But we do know audiologists who have adopted children with hearing loss, and we're continuing to kind of collect data, and we're also preparing the current data for publication, where we're going to go much more in depth and kind of look at some of those outcomes, not for audiologists specifically, because we didn't have them in our sample, but we did have some really interesting perspectives from other professionals, as Elizabeth had mentioned, who had perhaps worked as ASL interpreters, and then when they adopted a child, they fully intended to use ASL, but realized that there were challenges within their family of other family members, spouses, and siblings learning ASL, which kind of changed things a little bit. So we do have a lot of data that we want to dig into, and we would love to include audiologists in the future.
And there's a follow-up question from somebody else while we have you on, but it is, did you look at differences in answers based on the birth order of the, nope, that's not you. Sorry. Sometimes when people don't write through these or two, it's hard to sift through them. I'm so sorry. Okay. So Dr. Cejas, I have a question for you, or somebody has a question for you. And that question is, based on your experience during the pandemic, are there measures or protocols that you would recommend as standard of care even outside a pandemic situation, preferably those that can be used as screeners by audiologists, SLPs, TODs, or early interventionist providers to refer families and children for mental health services?
Yeah, and that's an absolute great question, and something that I'm super excited that over the years, it's been more of an open discussion across multidisciplinary teams, in that you don't need to have a psychologist or a social worker on your team, but you do want to start having those conversations with the families or the patients in your clinic. So actually at the University of Miami and in our recent publication, we did implement a screener for depression and anxiety across all of our patients who come to our clinic. And so those could include the measures that I presented on today, which is the GAD-7, which assesses anxiety in only 7 questions, or the PHQ-8, which looks at depression symptomatology in only 8 questions. So those are very simple questions that our patients 12 years and up are able to complete. You also can give that to the families, and they're only screeners. So I know sometimes even amongst our team, there's the uncomfortableness of talking about mental health, but it really all starts there with you just saying, this is something we're doing for all the families, all the patients who are coming in. And we just want to see how emotionally you guys are doing and whether or not you can refer for outside support.
Great, thank you. Kathryn, there's a great question for you, I think. This question is, and I have a follow-up question that I was thinking of as well when I was listening, but did you look or ask if the siblings themselves also had hearing loss? And then I also had a question about communication mode, because the, some of the outcome measures were, or the feelings were sort of determined based on the perceived difficulty of communication. So I was just curious if either if outcome measure or if communication mode was looked at as an outcome measure.
Thanks. Yeah, those are both really good questions. To address the first question about the hearing status of the siblings, we did ask the siblings who completed the questionnaires if they had hearing loss, and all of them reported not having any hearing loss. So this was a group of children who we would consider typical hearing. I would be interested to see if these perceptions or some of these relationships look different in children who have the siblings who have hearing loss themselves, which, we do see families, who have multiple children who use cochlear implants. So that would be, I think, interesting to look at as well. But we didn't look at that in this particular study. And then in terms of communication mode, that's another really good question. This group of children that we studied predominantly used spoken language as their mode of communication. So we didn't see any children who signed predominantly. But again, that would be another thing that I think would be interesting to look at. There is some literature on siblings of children who are deaf who use sign language, but that wasn't part of the study that we completed.
Thank you. There's actually one more question for you here too, which
Sure.
is sort of related to that. It says, do you have any information if the siblings had any other family members who were deaf, such as parents or grandparents or anybody else that they knew?
That's also a great question. So we didn't ask about that in particular, but I imagine that could have an influence on sort of their perception of hearing loss and how they sort of relate to their sibling if they had other people in their lives who also had hearing loss or used cochlear implants. But we didn't ask about that in the study.
Great, thank you.
Thanks.
There's 2 more questions for Elaine, if you can take that, Dr. Smolen. So there's the first one is, did the adoptive parents all know that the children were deaf or hard of hearing when they adopted them?
So that was a really fascinating aspect of our qualitative interview. Some of the parents did. They had received information in the medical pamphlet or packet reports that they had received on their child prior to the adoption, and others did not. Some had adopted their children with no known medical issues. Others had received pre-adoption diagnoses of other conditions or disabilities, and the hearing loss was identified later. And it was fascinating in our interviews to see how that played out clinically for the families in terms of their course of treatment, in terms of their adjustment and coping, and how that even further delay in identification of hearing loss and provision of technology and rehabilitation affected the child's ultimate outcome.
Great, thanks.
And then
I have
follow
sorry,
up
go ahead.
just briefly. I wondered what proportion of those adopted kids came from non-English speaking families, and did that seem to have an effect?
Yes, so that was another thing that we investigated, the influence of exposure to language pre-adoption. So some of the children were profoundly deaf and did not have technology. And so whatever language was being spoken around them, they probably did not have great access to it. Maybe they were able to pick up on some prosodic characteristics. But there were other children who had mild or moderate hearing loss, and even some who had received technology in their home country. And one of the things that some of the parents mentioned was the influence of that L1 on their subsequent development of English. And so that was really fascinating, because we know that in typically hearing children who have been adopted from a non-English speaking country, that there are effects. There's really nice work being done at St. Louis University on this, of just English language development in typically hearing children who have been adopted internationally. And so it was interesting to see that many parents whose children had some access to a spoken language other than English prior to adoption, how they felt that that influenced their English language acquisition.
Okay.
We also have another question for you as well. For adoption, did you look at differences in answers based on birth order of the children?
Question. We did not specifically look at that. We really wanted to look qualitatively overall at themes that kind of emerged, and not quantitatively, with those distinct independent variables. So we did not look at that. On experience, children, one of whom did. So we do have some interesting that we're kind of looking at now in terms of parents' experience and then a child, or having a younger child after they had adopted a child. So there's lots to look at there.
Great, thank you. And we'll keep going since we have a couple more minutes here and the questions keep coming in, which is great. So let's see, Dr. Cejas, we have one that is, how do you suggest clinicians broach the topic of counseling for patients or families exhibiting signs of mental health issues? And I think this is obviously really important, especially given the current circumstances.
Yes, absolutely. Starting that conversation can be difficult, but I think even in a team where we do have a multidisciplinary team with mental health providers on staff, the reality is that they don't come to my door, right? They don't come to see a psychologist first or a social worker. They are coming to work with our AVTs or our educators or audiologists, and so that trust is already there. And with implementation of a screener, oftentimes that just opens the door and already brings down the barrier to say, well, now I'm actively saying that I'm struggling with these areas. So it's simply, when you have a screener, you can just approach that in saying, well, we noticed that you kind of endorsed, or you said a few of these things, would you be interested in following up with someone if you have somebody on your team to help do this? Or what we have also done is kind of provide a community referral list. So that way you're not really asking all the detailed questions, but you still acknowledging and bringing it to their attention that you're aware that there are some things that might be impacting them emotionally. And then you can go ahead and refer to a community provider.
Thank you. Grace Johnson, there's another question for you as well. This might be the last one that we have, and it's a pretty quick one. But with reference to the previous question and private insurance versus Medicaid and the association with mastery of linguistic sounds, this question is that in reference to identification or imitation of the sounds, or just detection of those sounds?
So thank you for the question. It has to do with mastery of the sounds. So the audiologist that works closely, we went through all of the notes and we were able to read through the EMR notes and determine when and if the patient was able to master those 6 ling sounds.
Great. Thank you. All right. And I think that's about it. I think we're about out of time here.
Thank you so much, Kara, for doing a great job of handling the question in my absence. Yes.
No problem.
Wonderful session. Thank you.
Thank you, everybody. You guys all did great. It was wonderful. Thanks.
Yeah, the questions were wonderful. Thank you so much.
Thanks.
Bye-bye.